So it's my pleasure to introduce Dr. Nadim Kanj, who's currently an assistant professor at the American University of Beirut Medical Center since 1986. He's involved in clinical work, teaching, and research. He has chaired, moderated, and lectured in several national, regional, and international conferences. He's an ex-president of the Lebanese Pulmonary Society and is currently the director of the smoking cessation program at the AUB. Dr. Kanj, maybe just be gentle on us, just respecting our friendship. So we're all keen to hear about this.
Thank you. I'm not as loud as Faris, but I'll try to make my point and convince you that allergen-specific immunotherapy doesn't work. So anyway, I like the last slides of Faris because they, he saved me a lot of time in contradicting his pro for specific immunotherapy in asthma. So my job now in the coming few minutes is to tell you that it does not work and it's money making. So it's, Faris, you broke my heart and you stabbed me in my heart when you talked that allergen-specific immunotherapy works. Well, it's my job in the coming 24 minutes, 59 seconds to prove that it's not working. Few slides on some history. Leo and Noon from Britain was the first one who worked a little bit with immunotherapy. Unfortunately, he died at the age of 35, and we lost a great scientist at that time. So by history, it took some time to introduce to the States, and in 1950, the first controlled study was carried to evaluate immunotherapy in asthma. And the first thing, I will talk mostly about reviews. I know it's very easy and very, straightforward to pick on some articles that show that you are right. But when you check on reviews will tell you exactly what's going on. So this first review that I found in the literature by Fink in the 1985 spoke about some contraindications, not indications, and they sensed at that time that there is a problem going on with immunotherapy after 70 years of being used. And they spoke, as is known to everybody, that there are some reactions that we have to pay attention to, and it's very important that the patient should accept the immunotherapy to be effective. And they declared at that time that there is definitely a problem in scientific investigations of immunotherapy, and something should be done about these studies. So the conclusion was that immunotherapy was associated with some improvement and a decrease in bronchial sensitivity in the 8 studies that they reviewed, but they had to admit that it does not prove that immunotherapy is effective in asthma. And they talk about controlling the environment, which is, important to every one of us. So the conclusion from this first review is that further studies with careful patient selection, standardized allergens and allergen dosages, and placebo or drug controls should provide definite and necessary answers. So this first review wanted more and more studies. It's interesting that I will show that only the Cochrane library, which is a respectable definitely library, has been supportive of allergen immunotherapy. But it also, talked about the significant heterogeneity in a very number of comparisons. And they declared that at that time that we need to treat 4 patients to avoid one requiring increased medications. This is an interesting article because I think it's the only one in the literature that compares immunotherapy with inhaled steroids. And this was because most of the studies before this study, and this is done by, I think, the group of Canonica in Italy, they declared that all the studies before this study have failed to show that there is an advantage of immunotherapy over medications. But in this study, they have found that there is some advantage probably of slit on medications. However, they declared also that there is an absence in most of the problems of the patients, an absence of placebo, and a double dummy design was not feasible. The second is also from Giorgio Walter Canonica and his group, Pasalqua and the rest, about emerging sublingual immunotherapy drugs. And also they admitted at that time that we still need to clarify a lot of aspects to provide a clear evidence-based recommendations. And there are unmet needs that have to be dealt with. Okay. So more studies are needed. Even from this review, there are a lot of things that need to be evaluated still. Mechanisms of actions, pharmacoeconomics, optimal doses, identifications, benefit in polysensitized, duration of protection, no consensus of the degree of severity of asthma compatible with slit has been reached, and so on and so forth. So there are actually tens and tens of problems left with immunotherapy that need to be clarified. And the second Cochrane library, actually by Abramson, as Faris said, again repeated that there are some significant improvements. However, they also admitted after reviewing 88 studies that there is a significant heterogeneity in the number of comparisons. This is important also. This is by Linda Cox, Harold Nelson, Richard Locke, the famous people in allergy immunology. And they insisted at that time that there are a lot of issues that need to be asked for the patient to start allergen immunotherapy. So they admitted at that time, 2 years, 3 years ago, that immunotherapy is effective, and there is a confirmation of its efficacy for the treatment of inhalant allergies by pollens, fungi, animal allergens, dust mites, and cockroaches. But they again emphasize the fact that there are still a lot of troubles going on in immunotherapy. Even those authorities in immunotherapy admitted that there are, problems with the candidates, problems with slit not being FDA approved, and it might prevent the development of asthma in subjects with allergic rhinitis. They also again managed to mention the contraindications. And they finally said that the management plan must be individualized, with careful consideration given to the patient's preference. And the quality of allergen extracts available is an important consideration. So again, they also, another important issue is that there are no specific markers that will predict who will remain in clinical remission after discontinuing effective allergen immunotherapy, and should not be initiated unless the patient's asthma is stable. So if the patient's asthma is stable, why should we start allergen immunotherapy? I mean, this is something that all of us would think about. And the safety, I will not say that the safety of immunotherapy is a problem, is a big problem, but it's a problem in certain cases. All of us should know that immunotherapy could lead to fatal reactions, especially the subcutaneous one. And a poorly controlled asthma and the use of beta blockers and the rest, as was mentioned, is a contraindication to immunotherapy. Patients should be cooperative and patients should be compliant, and this I will touch on in a minute. And there are also, like there are adverse and anaphylactic reactions to a CIT, there is also adverse reactions to slit. Systemic reactions can occur. Of course, we had so far no fatalities, but there are a lot of severe reactions and anaphylaxis that happened with slit, and there are no FDA-approved formulations for sublingual immunotherapy. Another review also by Bousquet and his group. Also, he repeats the same things that the targeting of patients for allergen immunotherapy. And he mentions the recent developments. However, again, And again, they mentioned that there is a requirement for additional well-designed, well-executed, randomized trials in adults and children with allergic rhinitis and asthma, with a special focus on optimal patient selection, dosage, and treatment duration. This comes always in all the reviews. The reviews always stress about the negative aspects of immunotherapy. Another review, also a very recent one from the United States, again mentions the candidates for immunotherapy and also states that there is no current evidence that immunotherapy influences the evolution of established asthma in adults. The position of immunotherapy actually is quite controversial and confusing in the literature. I don't know exactly if I would like to start immunotherapy to a patient, where should I place this immunotherapy? So there are no specific tests or clinical markers. The decision to continue beyond 3 to 5 years also is not that straightforward. And again, the mentioning of the risk of anaphylaxis. Quite a recent review about allergen-specific immunotherapy speaks about the milestones from 1903 till 2006. And I hope these future things are going to be realistic at some time, because definitely they will give us a better immunotherapy than the one we have now. Again, slit mechanisms are still unclear, and there are less than 30% of the studies have shown only unequivocal clinical efficacy. And of course, the efficacy of slit is definitely much lower than the one of a CIT. A very recent one talking about some mechanisms of allergy and so on. This is interesting to all of us because they categorize the clinical effect levels to multiple effects: early effect, progressive effect, persistent effect, preventive effect, and immunological effect. In Asthma Principles of Treatment 2012, immunotherapy is effective in decreasing symptoms and medications in select patients. And patients receiving immunotherapy for allergic rhinitis may have a decreased risk of developing asthma. Another one puts the indications, and again, it may prevent. There is nothing sure about prevention of asthma by immunotherapy. Of course, the relative contraindications should be always kept in mind. So, patients with mild asthma are more likely to benefit from immunotherapy than patients with moderate or severe asthma, which may be at increased risk for adverse reactions to immunotherapy. And again, I repeat my statement: if it is a mild asthma, why should I give it immunotherapy? Sublingual has its problems, as we said. It's not FDA approved. The exact mechanism is not yet known, and it's much lower in effect than the subcutaneous. Many questions have been left unanswered, such as effective dose, treatment schedules, and duration of treatment. Sublingual immunotherapy, again, mentioned by Lynn in the JAMA this year. High-quality studies are still needed to answer questions regarding optimal dosing strategies, and there are limitations in the standardization of adverse events reporting. So there is a need of quite a lot of future research on to change these conclusions. Now, if these are the studies in favor, what are the studies not in favor? So we will again mention that it doesn't work and it's money-making. The first one that contradicted the effects of immunotherapy was the one by Atkinson from Johns Hopkins, and at that time he mentioned that, of course, as Faris said, it has been there for 100 years, but there is definitely a lot of other things nowadays. It's not so in the new millennium. The size of the therapeutic effect, if observed at all, is invariably modest and quantitatively comparable to the effects observed with any of a number of bronchodilators and chromonin-like drugs. No published studies have demonstrated a steroid-sparing effect for allergen immunotherapy. And a study done at Johns Hopkins showed no difference in the requirement of either inhaled or oral steroids between immunotherapy and placebo group. And a direct comparison of inhaled steroids and immunotherapy has not been done and is not likely to be done because of ethical and logistic constraints. Safety, I will not touch on this more. All of us know about it. Safety again. So unlike pharmacotherapy, immunotherapy provides no protection also against non-allergic asthma triggers as viral infections, irritants, and exercise. Immunotherapy will not work against these things. However, he noted at that time that there is some compliance which might be better with the immunotherapy than with the inhaled steroids, but this is also controversial because most asthmatics are treated by both, and this will make a confusion of the situation. Okay, so conclusions of this things that it's not clinically indicated, and the best clinical results are seen in younger patients with less established and or severe asthma, and so on. Best candidates for immunotherapy are children with mild to moderate asthma, severe perennial allergic rhinitis, and as yet few allergic sensitivities, preferably only dust mite. This went along to the British. The British are fierce oppositions for immunotherapy. I don't know why, but the British always contradict the effects of immunotherapy in all their literature. So the British guidelines will not endorse immunotherapy at all in most of the asthmatics and the allergic patients. Area. Okay, you mentioned area. This is what area mentions. Area mentions that they suggest subcutaneous immunotherapy, and it's a moderate quality evidence. And in sublingual, they also suggest, and it's a low quality evidence. Another British fighter against immunotherapy in the recent years mentioned that allergic asthmatics with mild disease is the patient group with eosinophilic asthma who generally responds well to standard anti-inflammatory treatments. So if we can treat the patient with some inhaled steroids, why should we give him immunotherapy? And sublingual immunotherapy at that time could not be recommended for the treatment of asthma in routine practice. Okay, wow. What does the wow, which is supposed to be to be a supporter of specific immunotherapy, document in the White Book on Allergy? And these are the big names: Canonica, Linda Cox, Pasalacqua, and the rest. They mention a lot of controversial aspects. There is no time to mention the controversial aspects in SLIT. There are large variability of doses, positive and negative results. Dose intervals are very, very wide range. No consensus of where is the best regimen, pre-seasonal, co-seasonal, pre-co-seasonal, or continuous. The build-up phase is a matter of debate. The no-up dosing is also not unanimously accepted, and so on. So these are quite a few of the controversial aspects. And there are controversial aspects for both SCIT and SLIT. The protein content of the extracts is highly variable. A lot of heterogeneity in the studies. Use of mixture of different allergens. No universally accepted system for the classification, grading of adverse events due to SIT. So there are a lot of unmet needs according to the WOW, and these are again what I mentioned: the dosing, the best regimen, the experimental design, single or multiple allergen exposures, and this is why they had a task force, and let's hope this task force will clarify these. GINA 2012 documents that inhaled steroids are currently the most effective anti-inflammatory medications for the treatment of persistent asthma. This is Braveheart, in the front. Okay, thank you. Okay. So GINA suggests that the role in adult asthma is quite limited. You have to identify and the use of a single well-defined antigen. Benefits must be weighed against the risk. and considered after very strict environmental avoidance and pharmacologic intervention, including inhaled steroids, when they have failed to control the patient. Gina mentions that no studies to compare specific immunotherapy with pharmacological therapy for asthma, and the value of immunotherapy using multiple allergens does not have support. Side effects, again. Gina, for children, it's not even mentioned. Allergen immunotherapy is not even mentioned in the guidelines of asthma 2012 in children. The Monaco chapter, again, said that the presence of allergists, here it's a different view a little bit, and they started to see why is immunotherapy not well known and not well practiced, and they mentioned that it's not known by the general practitioners or by the populations and so on. Well, this is another point of view we can discuss. And they mentioned at that time that there are barriers and unmet needs in the scientific aspects of specific immunotherapy, methodological shortcomings, bias in clinical trials, standardization. These are not met so far. And one of the things is the absence of reimbursement of SIT in most countries. Another view that might need to be discussed. Adherence to sublingual immunotherapy. In this study, it was even very poor. And the marketing data showed a disappointing rate of discontinuations, approximately 90% over 3 years. So most of the patients will discontinue their treatment in the coming few years. This is quite an important real-life study. If you meet Peter Barnes, Faris, he will definitely knock you down with me, because Peter Barnes believes that there is no role of immunotherapy in asthma. However, an interesting recent article tried to balance the different views of pulmonologists and allergists. And again, Peter Barnes started by saying that it's not worth performing allergy tests in asthmatic patients, since asthma therapy is the same whether asthma is allergic or not. And there are issues to be improved: heterogeneity of control trials, more rigorous methodology, quality of extracts, role of the allergen-specific bronchial challenge. Take a break now, and I will tell you exactly why I think specific immunotherapy is not believed by pulmonologists. All what you have heard so far could be the truth. And my nose will get longer if I talk something not the truth. So what do you think? What do you think? You are here. What do you think? Why don't we use immunotherapy? I'll tell you why. First, our journals. You know how much the chest journal, what do we read? We read the chest, the blue journal, the thorax, respiratory medicine, European respiratory journal. You know how many references of allergen immunotherapy since 1935 chest has written? Or how many articles? Only 3. ERJ since 1994, none. There has been no article on allergy immunotherapy from 1994 till now in the ERJ. Thorax since 1946, 1 reference only. Blue Journal since 1987, 1 reference only. Respiratory medicine since 1989, 1 reference only. So, how many times in chest, Blue Journal, thorax, ERJ, and respiratory medicine do you find the word allergen immunotherapy? 3 and 0 and 1 and 1 and 1 equal 6 since I was born. Okay, so you find only 6 articles about allergen immunotherapy in our 6 important chest journals. I know the rest comes from allergy, but if you are reading pulmonary journals, you will find no article about allergy immunotherapy. The second thing is that in chest alone, if you go to this 50, 60 years, inhaled corticosteroids have been mentioned 1,000 only in chest, 1,360 times. Second, Pinocchio, our pharmaceutical industry and agents. Fortunately or unfortunately, we have to see Glaxo, Astra, Novartis, Merck, Chiesi, Uniphar, Boehringer, Julfar, New All Pharma, Cipla, and the rest. And these do not deal with allergen immunotherapy so far. Whereas allergologists have to see only Stallergen. Stallergen is a respectable company. I know this. I have read about it. It has been there for several years, and it has been in more than 50 countries. But who knows from the pulmonologist Stallergen? Who have seen Stallergen? Who knows what Stallergen does? We don't know. So we have a lot of companies versus one company only. The third thing, what do we do in our specialty job? We do a lot of things. We do chest diseases, sleep, critical care, interventional procedures, plus minus allergy. What does the allergologist do? He does allergic disease and immunology. So he has to do these shots and these sublingual immunotherapies. Otherwise, he would not be able to do anything except by using our medications. So, third things, the available therapies for the pulmonologist: ICS, leukotrienes, ICS-LABA, anti-IgE, theophylline, SABA, LAMA, Crohn's, systemic steroids, and recently thermoplasty, besides a lot of Japanese medications that nobody of us know about. What does the allergist do? The allergist do SIT and the rest of the medications also that we use. So, fifth and most important, which I'm ready to, challenge or to fight for, is that there are no placebo in many studies. I know there are placebo in studies, but there are no placebo in many studies. And there are no long-term studies. Usually, though Faris has shown that one of them for 14 years, but the majority of studies have been less than 10 years, and FDA not approved. So is it a charade or an act? We have to see. So what I would like to finish by take-home messages, again, that immunotherapy might be effective in decreasing symptoms in selected patients, may have a decreased risk of developing asthma. Requirements for additional well-designed, well-executed, randomized studies are very much needed, and there is no current evidence that immunotherapy influences the evolution of established asthma in adults. No specific tests or clinical markers. There are a lot of controversial aspects, unmet needs, and barriers to the use of SIT. Issues to be improved have to be considered. Real reasons have to be analyzed further. And of course, we need long-term studies are needed. Otherwise, SIT will become like rare speeches, like these speeches you see here, if they don't do some more studies and some more controlled and definite randomized and placebo-controlled studies. SIT will disappear and vanish, I think, like these rare speeches soon. And thank you.